everyone. Welcome you all for today's webinar on Oncology Cancer Treatment Updates 2024. With immense pleasure, I would like to invite Dr. Sunil Kumar Gupta, who is Director and HOD Department at Hematomedical Oncology and Bone Marrow Transplant in Venkateshwar Hospital, New Delhi. The stage is all yours, sir.
Thank you, Sarvangi. Very good evening, dear friends. There is so many update in a cancer treatment, and lung cancer is one where we are having a daily some update. If you see in last 2 decades, we are talking about the first generation TKI when there is a EGFR mutation seen in adenocarcinoma, then second generation TKI, and then third generation TKI. Even the histopathology in 2 decades changes from squamous cell carcinoma to the adenocarcinoma predominantly, and this is surplus from the squamous cell carcinoma. So today we have 4 speakers who will share their experience and update our knowledge regarding the lung cancer. We have an overview of lung cancer by one of our experts, and we also see the third generation TK exceptional role even in T7-9 mutation or the other mutations where the third generation TK play important role. The important thing is ultimately we will review the third generation TKI osimertinib role in adenocarcinoma lung cancer, even in early stage, advanced stage, and in adjuvant setting. And third thing, which is very important, is that once there is a disease which is spread to the brain, which TKI crosses, and third generation TKI, especially the osimertinib, crosses the blood-brain barrier and giving a magic results. We will discuss that also. For the first deliberation, I would like to call Dr. Jyotika Jain. She is a director and head of the Department of Radiation Oncology at Narayana Super Specialty Hospital, Gurugram. Dr. Jyotika Jain is a renowned oncologist, and she will discuss regarding the overview of lung cancer. Dr. Jyotika Jain, please.
So, thank you very much, sir. Thank you very much for giving me this opportunity. So, we are just going to lung cancer. Basically, if we first, can I get the slide, please?
Is my screen visible, ma'am?
Yes.
Screen is visible, but slide. Yes, visible. Thank you very much. So, today we are going to discuss about overview of lung cancer. Next slide, please.
Go to next slide, Swarangi.
So, if we talk about the burden of lung cancer, worldwide is one of the most common cancers. If we see the incidence of lung cancer in India, in both the sexes, it 72,000 cases per year. And if we talk about males of all ages, new cases per year, they are to the tune of 51,000. Now, if we see the rank of lung cancer as compared to various other malignancies, please can you move further? So lung cancer rank around 4th in new cases. And if we see mortality also, that is also 4th in the rank. So this is one of the leading cause of concern or mortality related to lung cancer. Next slide, please. Next slide. Next slide. So for any basic treatment, basically we require the optimum staging. Previous slide, please. So optimum staging is most important. And we have seen like in AJCC, previous slide, please. Yes. So optimum staging is required to decide the best treatment options. So if we see the 7th edition of AJCC and 8th edition of AJCC, there are few changes as per the size of the tumor. If we see T3 and T4, there are few changes. Earlier, up to 4 centimeter tumors, they were considered in T3 T3 tumors, and now they have changed it to T4 lesion if lesion is more than 7 centimeters. And there are few changes in the size of T3 also, which is making it upstage to upstaging of the tumor stage. So size is a criteria by which there are few changes which is leading to upgrading of the stage. Next slide, please. Now, so a proper staging is required for deciding any particular treatment. CT chest is the commonest investigation by which we see any lesion in the lung, and later on we proceed further. So either we get a CT guided biopsy and later on, or depending upon location of the tumor, we require bronchoscopy, PET CT, EBUS, EUS, mediastinoscopy, or MRI brain. So basically various investigative tools they are required for proper staging. Next slide, please. So, in any particular CT scan, if any lymph node which is more than 10 millimeter in the short axis, that is a predictor of malignancy. But if we are doing CT alone, that is having low sensitivity to the tune of 55% and low specificity, that is around 81. But if we combine the PET with the CT, then the sensitivity increases to 80 to 90% and specificity increases to 85 to 95%. So basically in lung cancer, PET CT is a modality which really helps us in accurate staging. Next slide, please. So now there are, for appropriate staging, sometimes there are occult lymph node metastasis, like in the sense N2 disease. N2 is very important because once it is there, then practically we are having surgery out and we are going ahead with CTRT. So any occult disease in the node at N2 station. So there are few factors which guide us. Like in those cases, we have to investigate any occult N2 disease. When any central tumors they are there, and if size of the tumor is large, and or if SUV on the PET is high, like if it is more than 4. So in all these states, we need to investigate further to see any occult disease in at N2 station. Next slide, please. So once and for medicinal staging, we first go for less invasive techniques like EUS, EBUS, and biopsy is done. But if doubt of other lymph nodes they are there, we go ahead with invasive mediastinoscopy, like either conventional or VATS. We'll have to see what is the location of the lymph node, and according to that, invasive mediastinoscopy is required. Next slide, please. So first we recommend EBUS or US, and if that is not lymph node stations, they are not reachable, and doubtful lymph nodes they are there, we have to take help of invasive mediastinoscopy. Next slide, please. So when we go for invasive mediastinal staging, uh, centrally located tumors. In those cases, we require mediastinoscopy. If any tumor is more than 3 centimeters, in those cases, or if extensive infiltration of mediastinum with no evidence of extrathoracic disease is there, or if N1 is there, in those cases, we need invasive mediastinoscopy. If any bulky N2 is there on the CT, there is no need to go for invasive confirmation. But if discrete N2 is there, yes, regardless of PET, we require invasive mediastinoscopy. If normal mediastinum is there on CT, but positive on PET, we go ahead with scopy. And if negative on PET, there is no need. Next slide, please. So this is the algorithm where we see on PET what are the lymph node stations, as we have already discussed. We proceed with mediastinoscopy for confirmation of exact stage so that further treatment can be decided accordingly. Next slide, please. So these are basically various lymph node stations which we can assess with EBUS, EUS, cervical mediastinoscopy, extended mediastinoscopy, right-left VATS or WIMLA or TEMLA. So basically whatever suspicious lymph node stations they are there, we have to combine various modalities. first we try for non-invasive. If it is not possible, then we go ahead with invasive. So confirmation of staging is important. Next slide, please. So, as we have already mentioned, non-invasive as well as invasive modalities, CT, PET, EBUS, US, mediastinoscopy. Depending upon various stations, we have to choose, pick and choose, depending upon which stations they are involved or suspicious for lymph node metastasis. Next slide, please. So now coming to the evolution of therapy. So in earlier days, years back, there used to be just lung cancer, small cell and non-small cell carcinoma. So slowly histopathological subcategorization was there. Like it was small cell or non-small cell. In non-small cell, there was adenosquamous, large cell, non-squamous differentiation. Later on, molecular subclassification came into picture in which EGFR, AL, cross, major these target molecular mutations they were there, and later on PDL1 expression and tumor mutation burden they were studied, and whole treatment paradigm that has evolved with the period of time and various new modifications. Next slide, please. So it was seen that advances in the management of non-small cell carcinoma has led to really improvement in overall survival. So from 2014 to 16, when a lot of targeted agents they have been approved, so that has led to basically improvement in overall survival in these patients. Next slide, please. It was published in NEJM in I think 2020. Yes. Next slide. So there are various advancements in the treatment of non-small cell lung cancer in early as well as late stages. So if we see year-wise, from 2006, like initially chemotherapy used to be the standard, and later on various targeting agents they came into picture, and later on various immunotherapy, immune checkpoint inhibitors they were added. So they have led a significant increase in the approval significant increase in approval of both targeted as well as immunotherapy in non-small cell carcinoma has been seen, and which has improved the survival in most of the patients. Next slide, please. So, if we see the increase, there is really an increased need of molecular testing in non-small cell carcinoma. At least 7 to 8 new targeted new mutations they are there, which are targetable like EGFR, AL cross, BRAF, and NTRK, METRET. So, in these, in any particular non-small cell carcinoma lung, molecular testing should be standard of care in all of them, because we have a lot of targetable mutation agents which will be really helpful in the patient to the patient. So all patients with non-small cell carcinoma lung should undergo molecular profiling to identify targetable alterations. Next slide, please. So now if we see the current guidelines on neoadjuvant and adjuvant chemotherapy depending upon the disease stage and finding during surgery. So it was seen like in stage 1A, patient can be observed. So no role of basically neoadjuvant or adjuvant chemotherapy. In stage 1B, 2A onwards, in 1B, if lesion is more than 4 centimeter in those cases, and with few uh, high risk features, if they are there, in those cases, there was benefit of adjuvant chemotherapy. So 2B onwards, definitely adjuvant chemotherapy is recommended. And if we talk about 3A and 3B, in 3A, you can go ahead with neoadjuvant chemo or adjuvant chemo. Or if N2 disease is there, we go ahead with concurrent chemo radiation. Next slide, please. So findings at the surgery and surgical resection margins, they also affect the adjuvant treatment. So for early stage disease, there 1 or 2A observation or chemotherapy in 1B, as I have already mentioned, in 1B and 2A. But if any positive margins there, we have to keep in mind in those cases, if it is R1 resection, you go ahead with addition of radiation is there, in either you go ahead with resection or you go ahead with local radiation with concurrent chemotherapy. But if R1 is there, you go ahead sequential. If R2 resection is there, in those cases, you add concurrent chemotherapy. That goes for preference. Next slide, please. So after initial treatment, more than half of the patients with resectable non-small cell lung cancer, they experienced recurrence within 5 years. So overall, there was still a need to improve the results in patients with resectable non-small cell carcinoma. Next slide, please. So further, it was studied uh, to see the effect of any adjuvant chemotherapy. So this slide I'll discuss later on. Please, next slide, please. So there was LACE meta-analysis in which they studied the effect of cisplatin in early small cell, non-small cell lung cancer. It was a pooled analysis in which 4,000 plus patients they were there, and it was seen that if chemotherapy was added, that was leading to basically absolute benefit of 3.9 to and 5.4% at 3 and 5 years respectively. So then the role of uh, adjuvant chemotherapy. So they studied cisplatin and vinorelbine, and like cisplatin-based chemotherapy was is required became the standard of care to improve the overall survival. Next slide, please. So then a few studies they were done, like in can we give induction chemotherapy? So it was studied like in almost neoadjuvant or adjuvant setting in stage 1B to 3A, where surgery was a bit difficult for the surgeon. In those cases, even neoadjuvant chemotherapy is one of the options, and results they were equivalent with both the groups. So option of neoadjuvant chemotherapy, induction chemotherapy, that can be there in case of if that is needed. Next slide, please. So then came like improving survival in resected EGFR mutated non-small cell carcinoma. There was ADORA trial in which patients with the completely resected stage 1B, 2, and 3A with EGFR mutation positive. In these patients, they were either given a placebo or osimertinib, and it was seen with the introduction of EGFR TKI, disease-free survival that improved from 44% in placebo to 90% in EGFR TKI arm at 24 months. So now it is possible to further improve survival in completely resected patients with stage 1, 2, 3 non-small cell lung cancer with those who are having EGFR mutation. Next slide, please. So later on, it was seen like if atezolizumab, which is basically immune checkpoint inhibitor, so it was seen that uh, atezolizumab showed an improvement in disease-free survival as well as overall survival in the adjuvant setting. Next slide. Okay. So now coming to the radiation. Basically, there are a lot of advancement in the field of radiation. Earlier, we used to have conventional fractionation. Now we can have intensity modulated radiotherapy. In that, you can you can modulate the beam intensity, and you can save a lot of structures in the adjoining area, like in any locally advanced disease where basically cardiac, lung, or esophageal toxicities, they are there. With the help of intensity modulation, you can save adjoining sectors, and you can reduce the doses to the heart with lower rates of grade 3 toxicities to heart as well as lung. Next slide, please. So basically it is important, and if a very small lesion is there, you can go ahead with stereotactic radiotherapy. Like in if any early stage lesion is there, T1 T2 lesion is there, and patient uh, is not opting for surgery, or there is some patient is not willing or surgically non-operable. In those cases, early stage disease, You can give very high doses of radiation to the tumor, which is completed normally in 1 to 5 fractions, and which is a short treatment. So normally in node negative patients and up to 5 centimeter, you can go ahead with this technique, which is called stereotactic body radiotherapy. And with these newer techniques, you can save normal structures dosages, and you can give a good dose to the tumor. Next slide, please. Next slide, please. So now there are a lot of new techniques like 4D CT planning and IGRT. The 4D CT planning, in which patient is respiring, and in particular phase of radiation respiration you treat, so that very small margins they are given around the tumor, and you can decrease the toxicities to the normal structures. You can do image guidance, like on machine you do CTs and you match the two, and if there is any regression in the tumor, you adapt in the sense you replan the tumor, so that normal structures they can be saved. So very small target volumes with lower doses to the normal tissues, including lung, esophagus, and heart, can be delivered with newer techniques. Next slide, please. So if we say it was a phase in RTOG 0617 was a trial in which they studied whether the escalation of the dose will that help, and addition of cetuximab with radiation will that help. But it was seen that there was no benefit of dose escalation, as well as cetuximab addition has not given any useful benefit. Next slide, please. So again, now we are coming similar slide which we have seen earlier, like chemotherapy with or without radiotherapy is standard of care after a complete resection of tumor in patient with stage 3 small cell non-small cell lung cancer. So basically, emphasis is there, like if any patient which requires radiation and chemo, you basically require a multidisciplinary team approach. Sometimes patient is unfit for chemo, or sometimes patient is not suitable for large field of radiation. So combined decision can be taken up depending upon the extent of disease, with the help of with a combined discussion with the surgical, radiation, medical oncologist. So a multidisciplinary approach is required in all patients. Next slide, please. No, so there was a Pacific trial. Checkpoint inhibitors is moving in the early stage, unresectable stage 3 non-small cell lung cancer. In Pacific trial, it was a randomized double-blind placebo-controlled trial in which there was consolidation with durvalumab in unresectable non-small cell lung cancer. Next slide. It was seen that durvalumab demonstrated 42.9% overall survival at 5 years in comparison to historical oral survival in unresectable stage 3 lung cancer, which was to the tune of 15 to 25%. So basically, immune checkpoint inhibitors are post CTRT in the adjuvant setting in unresectable non-small cell lung cancer. They have shown really improvement in survival. Next slide, please. So now there is emerging treatment paradigm in non-small cell lung cancer, as we have discussed, targeted therapy as well as immunotherapy, which has improved the response rates and survival in almost all patients. Next slide, please. So we see that with chemotherapy, median survival used to be 5 to 7 months, but with EGFR TKIs, if that there some mutation is there, you are using EGFR or ALK inhibitors. With EGFR, there was uh, increase in PFS around to 18.9 months, and with ALK inhibitor it was 34.8 months. So if we see before the era of EGFR, like targeted agents, it used to be progression-free survival used to be very small, 5 to 7 months. With these, lot of difference has happened. Next slide, please. So there are emerging molecular targets in advanced non-small cell lung cancer, like in MET, RET, NTRK, and HER2 mutations. We can have crizotinib, cabozantinib, vandatinib. Lot of newer targeted agents are being identified. This will help increase survival in these subset of patients. Next slide, please. So we can see historically with recent advances, survival rates are improving compared to chemotherapy alone. If we see with chemotherapy, response rates, they were to the tune of 8 months, 12 months, 14 months. But with EGFR, ALK, these inhibitors, basically targeted agents, we can see in survival of up to 39 months and 24, 35 months. So a lot of changes they are occurring. So from 12 to 14 months, which used to be the best, now whole of the paradigm is shifting, and we are having good survival with targeted agents. Next slide, please. So now coming to immunotherapy, immune checkpoint inhibitors as PD-1 and PD-L1 inhibitors, we have seen they are also giving in those patients where mutations they were not there, even in those patients, they are doing really well. We are having real good improvement in survival. Next slide, please. So if we see from 2015 to 21, lot of immune checkpoint inhibitors, they have got approval. As mentioned earlier, patients when they were before 2016 and all, as published in NEJM results, they were poorer, and overall survival of lung carcinoma patient, non-small cell lung cancer, that has improved really well post introduction and approval of all immune checkpoint inhibitors. So large number of immune checkpoint inhibitors, they have been approved, and they are giving really good results. Next slide, please. So we can see historically, again, as mentioned earlier, with chemotherapy, just survival is 12, 14 months. And but with those patients who are not having any mutations, but PDL1 positive patients, they are having survival to the tune of 22 months, 19 months, 30 months. So they are really playing a good role in good outcomes of patients without even molecular alterations. Next slide, please. So checkpoint inhibitors, they are improving survival, and they are really advantageous even in stage 4 patients. Next slide, please. So it was a keynote trial 024, which showed improvement in survival in patients with pembrolizumab compared to chemotherapy, where PDL1 TPS was more than 50%. So almost 32% of the patients, they are alive at 5 years with the use of IO in metastatic non-small cell carcinoma. So practically we can say in all patients where um, PDL PDL1 TPS score is high, they really do well with the immune checkpoint inhibitors. Next slide, please. So now multiple ongoing trials they are going on, and which are assessing the role of ICI in adjuvant setting, perhaps PEARLS and Keynote 091. So we'll be getting those results in near future, and perhaps that might change the treatment options in these patients. Next slide. So now antibody drug conjugates is a concept which is being studied well in breast cancer, and now a few more studies they are coming up with the non-small cell carcinoma lung. In near future, perhaps we'll be getting some more molecules to be used in these patients. Next slide. So now coming to CAR T cell therapy, which is a new concept in which the T lymphocytes, they are modified taken from the patient, modified and re-injected inside the patient so that they can detect the antigen and tumor cells and they can kill. So this is basically CAR T cell therapy. This is a new concept which will be helping in lung carcinoma. Next slide. So basically, I'll say the takeaway message is management of landscape is fast changing in non-small cell carcinoma. Neurotherapies have a huge potential to improve the survival, especially when detected in early stage. The overall survival has improved across various subtypes with molecular alterations. The ease of oral pill over infusion in cases of targeted therapy is an added advantage. Pulmonologists will play a huge role in the early diagnosis, hence it is crucial to involve them in the non-small cell tumor boards. Thank you.
Thank you, Dr. Jyotika, for such an excellent talk to basically enlighten the new molecules, the checkpoint inhibitors role, specifically the radiotherapy play important role in lung cancer. Thank you very much. And I would like to call our second speaker, Dr. Sneh Bothra Jain, consultant at Mittal Bhilai Hospital, Mittal Institute of Medical Sciences, and she will tell us about the exceptional response to ositinib third generation TKI in EGFR mutation metastatic lung cancer. I would like to call Dr. Sanay Bothra Jain for his deliberation.
Thank you, sir.
She's a medical director and senior consultant also.
Good evening, sir.
Good evening. Good evening.
Good evening, sir. Thank you. Thank you for this opportunity, sir. Without wasting much time, we'll start with the presentation. So we have seen a great presentation over the overview of lung cancer and how the metastatic lung cancer has evolved over the years, especially the EGFR mutant lung cancers, which have now moved from chemotherapy alone to targeted therapy to chemo plus targeted, and we are having significant advances as time goes on. Just and So we'll just go through a quick case and how osimertinib helps in these patients. So this is a gentleman, 64-year-old, with presented with cough and progressive breathlessness and severe backache. He could not walk without support over the last 10 days, and he had some giddiness of about a week, significant weight loss, and was a non-smoker. Now, he was evaluated, and he was found to have a mass lesion in the right upper lobe with hilar nodes and multiple bone metastasis. Because of giddiness and inability to walk, he also underwent a MRI scan, which we will be looking ahead. He underwent a biopsy from this lesion, and he underwent molecular studies as well. So histopathology was adenocarcinoma, which was TTF1 positive, and molecular analysis was suggestive of EGFR mutation, exon 19. PDL1 was negative, and all the other targetable mutations were negative. MRI brain was suggestive of a significant number of metastases, multiple ring enhancing lesion in the cerebrum as well as the cerebellum, with perilesional edema and vasogenic edema. So the patient was finally diagnosed to have a stage 4 non-small cell lung cancer, exon 19 deletion, with bone and brain metastasis. So initially, if this was, I guess, about 5 to 10 years back, then we would be treating this patient with chemotherapy, radiation, and probably telling them that we are not going to have much time. But in today's time, things have changed quite a lot. Because this patient was symptomatic, he underwent local radiation and he underwent EGFR, and he was started on EGFR TKIs. In today's time, he would have rather been started on EGFR TKI as well as chemotherapy. So just to go over the various TKIs that are available, initially it started with geftinib, erlotinib, then came afatinib, dacomatinib, and then finally osimertinib with the highest progression-free survivals. We need to understand that where do we put osimertinib over the others, considering cost and all the other things. The first thing is patient with CNS disease. This is the preferred choice of treatment. considering the fact that afatinib has a good brain penetration and a very good CNS activity and can be used in both parenchymal as well as leptomeningeal disease. So, this is the table suggestive of the brain is to plasma ratio, and we can see that there is a significant brain penetration as compared to all the other TKIs, which includes gefitinib and afatinib. So, osimertinib is about 3.5 times more penetrant into the brain as compared to the plasma ratio itself. So this was the regional distribution, and this is the PET-CT scan or functional PET-CT scan of individuals with osimertinib. So we can see that there is significant uptake in most of the subjects. This is the next CNS degree of penetration in two other patients, where on day 21 of osimertinib, there is significant penetration into the brain and a good CNS activity. So how do we manage a patient with EGFR mutant NSCLC and CNS metastasis? So if it's a newly diagnosed EGFR mutant NSCLC, if there is brain metastasis symptomatic, then in that case, we do a local therapy. If not, then we can start with osimertinib plus minus chemotherapy. If this patient has a progression of on first or second generation TKI with a brain metastasis, in that case we can and they are symptomatic. In that case, the patient can undergo T790M mutation, and if there is CNSPD alone, then osimertinib, and if there is a T790M mutation negative, then local therapy and then continue TKI. But if there is systemic and CNS progression and the patient is T790 mutation, then osimertinib. But if the patient is T790 negative, then we have to let the patient undergo chemotherapy and local therapy. So basically, the most important thing is that we might miss a chunk of patients if we start on first and second line generation TKI. We might miss a chunk of patients who are T790M negative. So coming back to treatment, in the FLORA trial, which is the major trial of osimertinib, patients with known metastasis and with no known metastasis, in both the cases, osimertinib was having better better PFS as compared to the standard of choice, which was first line EGFR TKI, first generation EGFR TKI. And in both the cases, the hazard ratio is 0.47, where we can consider using osimertinib, particularly in patients with CNS metastasis. Now, looking at the other TKIs and their brain outcomes, consider afatinib. If baseline asymptomatic patients, Lux Lung 3 and 6, where response rate was about 70 to 75%, and the median CNS PFS was about 8.2 months. Looking at FLORA trial, approximately 15.2 months versus 9.6 months in other EGFR TKIs. So I think osimertinib is one thing which definitely takes one step ahead over all the other TKIs in case of brain metastasis. So this patient received palliative radiotherapy to spine for backache with zoldonic acid. Patient denied brain RT and wanted to see later whether what needs to be done if there was no response to the TKI, and was started on osimertinib 80 mg per day. So a follow-up PET-CT scan about 6 months later was suggestive of significant response to the local region, that is the local nodal mass, as well as the paratracheal nodes. And the brain MRI was suggestive of near complete response to these brain metastases without the use of radiation. Complete resolution of brain lesions and no additional intervention was needed even 1 to 2 years down the line. So there have been multiple case reports of osimertinib and brain metastasis. So this is a 53-year-old gentleman who relapsed while being on chemotherapy for stage 3A. Subsequent scan revealed pretracheal nodal hypermetabolism, and from repeat brain MRI, she was found to have multiple brain metastases with surrounding edema. She was started on osimertinib 80 mg daily. Patient complained of significant worsening of ataxia in the following days and was scheduled for craniotomy and tumor resection. However, when osimertinib was started, there was significant decrease in the lesion and there was complete resolution over next 2 to 3 months. There are other cases where there is complete remission of brain metastasis in EGFR mutant NSCLC with first-line osimertinib without radiotherapy. So whether symptomatic or asymptomatic, if the patient denies getting radiation, we can start with osimertinib with due consent and understanding that they may progress and may need radiation. And multiple studies have demonstrated significant effect and efficacy in CNS metastasis. So this was a phase 2 trial, prospective proof of concept pilot study of 48 patients, where EGFR mutant NSCLC received 80 mg of osimertinib daily. Patients were either treatment naive or previously treated EGFR TKI and T790M positive. In case of isolated intracranial progression, osimertinib dose was escalated to 160 mg, and the endpoints were objective intracranial response and disease control rate. So this was the median PFS in this was 11.8 months, and the median ORR was 84.2, 66.7, and 50% in these three target groups. So osimertinib demonstrated high efficacy in brain metastasis, and all trial arms displayed a significant decrease in number and diameter of target lesion. Findings suggesting that osimertinib is effective for T790M mutation positive as well as negative asymptomatic brain metastasis patients. So on further follow-up scans over the next 1 year, the patient continued to be in remission and almost complete responses everywhere in the brain as well as in the local areas. So radiotherapy for brain was not needed, and still patient had complete resolution. There was complete resolution in the primary disease and nodes. There was no adverse events that were reported by the patient, and the patient remained progression-free even after 19 months after initiating osimertinib. He was fully active and asymptomatic, going and leading a normal life. So the most important thing here is excellent response to osimertinib. Is there any specific biomarker that can help in predicting the excellent response? And are the tumors different from the other tumors who progress in 6 to 8 months or about a year? So this is what we need to just have a thought about. And thank you. Thank you for patient hearing.
Thank you, Dr. Sane, for such an excellent talk regarding the exceptional response of a third generation TKI osimertinib. Dr. Jyotika, Dr. Sneh, and Dr. Bansal. Means I have a question in my mind. A patient who had a surgery first as a early stage lung cancer and adjuvant TKI osimertinib, and 2 years later, patient has a brain mets. And you know that third generation TKI crosses the blood-brain barrier only the osimertinib, and there is a brain mets after 2 years. Dr. Jyotika, what is your opinion? Dr. Jyotika is having some connection problem. Dr. Sane, Dr. Mukesh Bansal.
Sir, can you repeat the question, sir? I just lost
Please, okay. The patient who is having early stage lung cancer.
Yes, sir.
Okay. And curative surgery done, but patient required adjuvant treatment in consideration of post-surgery finding, and patient was on a third generation TKI osimertinib, and 2 years later she developed the brain mets. How you will approach in such a patient, those who are on a osimertinib as an adjuvant setting, but has a developing a brain mets symptomatic?
Right, sir. So in that case, we could, first thing is we could look for a T790M mutation.
Yes.
Could do a liquid biopsy and look for a T790M mutation. Although already the patient is on osimertinib, we could look for other mutations as well, which is causing resistance. And because the patient is symptomatic, we could go ahead and treat the patient with, if there is a single brain metastasis, then SRS. And if there are multiple, then whole brain RT would be the preferable choice. And then as per the further NGS reports, as to what the patient has and what is the reason for this mutation, what is the reason for this progression, we could treat them accordingly, or we could even double the dose if we don't find anything else. And if it is still EGFR mutant, then we could double the dose of the osimertinib to 160 mg per day.
Yes, Dr. Sane. Dr. Mukesh, any comment from your side? Dr. Mukesh Bansal?
Sir, I think patient was still on osimertinib, sir. He or she was taking osimertinib and she developed brain.
Yes, adjuvant setting, 2 years osimertinib, then suddenly the scan suggestive of a brain mets. What
I
you will
think
do, basically
if
in adjuvant setting, I am talking about adjuvant setting
yes,
osimertinib, 2 years
yes,
later,
yes,
as
sir.
Dr. Sneh mentioned about that, she will check the mutations and specifically the T790 mutation and other variants. And if possible, oligomats or up to 3 to 5, she will go for SRRT brain
Yes,
mets.
sir. Otherwise,
So,
whole
what is your
brain.
opinion? Any suggestion? Any comments?
Sir, if the brain mets are symptomatic and if there is solitary bone met or up to 3 to 5 small mets, then I will do SRS and will continue with the complete the course of osimertinib. If there are multiple symptomatic brain mets, then obviously this whole brain RT is required. But if the brain mets are asymptomatic, I think then we can continue because osimertinib crosses the blood-brain barrier, has activity inside the CNS, and we can continue. We can go for a mutation testing as suggested by Dr. Sneha, also T790 and others.
Dr. Sane, would you like to re-challenge again if patient received the cranial radiotherapy, even the stereotactic radiotherapy, and complete response is seen? Would you like to re-challenge with the third generation TK, or would you like to change your plan if there is no mutation?
So if there is no mutation and there is nothing else on NGS, as in no MET amplification or no other mutation leading to resistance, then we could continue with the same dose, or we could even double the dose for that matter,
Yes,
if
yes,
tolerating. So
yes,
160 mg per day would be a good idea to switch to in
yes,
case the patient is able to tolerate that dose. And if there is
yes,
systemic disease as well, in that case, then we need to do the biopsy from a new site and try to look for something. And we
yes.
could even start chemotherapy and keep the patient on chemo plus osimertinib for a longer responses for this patient.
Dr. Mukesh, would you like to add anything with your experience in your clinical practice?
Sir, I agree with Dr. Sneha. I think in that case we can go for the combination chemotherapy also, and doubling of dose is also an option.
Okay. So, Dr. Mukesh, now this is now your turn. Dr. Mukesh Bansal is a consultant medical oncologist and hematologist, Alchemist Hospital, Panchkula, Chandigarh, DINB Medical Oncology, ASMO. I would like to say that he will tell us about the advanced EGFR mutation in non-small cell lung cancer, the evidence-based review of targeted therapies, and he will enlighten us regarding his experience and randomized trial and the guidelines. Dr. Mukesh
Good.
Bansal, please.
Good evening, sir. Good evening, organizers, for giving me this opportunity. Can someone share my slides from the
Yes, I'm
host?
sharing.
Yeah. Yes. So as we are discussing EGFR lung cancer, and obviously detailed lectures have been taken by Dr. Sneha and others. So the topic given to me is advanced EGFR mutated non-small cell lung cancer, evidence-based review of targeted therapies. Next slide, please. Yeah. So coming to the background, lung cancer is a very common cancer. As of 2020 data, it is the second most common cancer diagnosed in males and third in females. It is the number one cause of cancer-related mortality in males and number two in females. Talking about India-specific data, it is the fourth leading cause of cancer-related death in India and fourth overall in the incidence. So non-small cell lung cancer is the most common type of lung cancer. Next slide, please. So the survival as in any cancer depends on the stage. So relative survival rates vary by stage and diagnosis. Uh, Less than 5% of the patients are getting diagnosed in stage 1 and 2. Majority of the patients are getting diagnosed in stage 4, almost two-thirds of the patients. If we look at the 5-year overall survival outcomes, it decreases with the increasing stage, starting from around 92 to 83% in the first stage and coming to almost 10% in 4A and nothing kind of zero in 4B. So it is very important to early detect the patient and start the treatment. Next slide, please. Next slide, please. Next. Yeah. So more than 50% of stage 4 non-small cell lung cancers have biomarkers. There can be two kind of biomarkers. There can be predictive biomarkers that are indicative of therapeutic efficacy because there is an interaction between the biomarker and the therapy on patient outcome. There can be prognostic biomarkers which are indicative of patient survival but independent of treatment received because the biomarker is an indicator of the tumor aggressiveness. So NCCN recommends testing for several genetic mutations and for PDL1 status in advanced non-small cell lung cancer to determine whether they can receive treatment with targeted agents. As we can see in this diagram, the most common mutation found is EGFR mutation, which is there in around uh, not the most common mutation is not EGFR, while it is KRAS mutation. The most common mutation for which we have therapeutic treatment available is the EGFR mutation in around 17% of the patients, while ALK rearrangement is there in around 5 to 8% of the patients. Other mutations like BRAF, NRAS, MAC, PIK3C are relatively rarer. Next slide, please. So testing methodology for targetable mutation, I think this is the old slide when we used to do EGFR by PCR and ALK and Roche confirmatory by FISH, but can be done on ISC also and PDL1 by ISC. Nowadays, NCCN recommends to it is to be done in a panel-based testing by NGS so that we can preserve the tissue and can do all the recommended 12 to 18 mutations at least. Similarly, in the NGS. Next slide, please. So EGFR driver mutations in lung cancer, the most frequent sensitizing mutations occur in exon 19 and 21. There can be exon 18 mutations also, G719C, S and A. Exon 19 mutation is there, exon 20 mutations can be there, and 21 L858R and L861Q. Next slide, next slide, please. So based on a limited number of studies, the prevalence of EGFR mutations appears broadly similar across disease stages. Overall estimated prevalence, it is said that EGFR is more common in Asian population as compared to the white population of the other races, around 30 to 40% of the patients. Prevalence estimates for each stage, all the stages have EGFR mutation, and the prevalence is almost same. So if EGFR TKI were available in the resectable setting, a similar proportion of patients may be able to benefit compared to the advanced setting. Next slide. So NCCN recommends EGFR testing in early stage non-small cell lung cancer also. The responsiveness to oral EGFR TKI therapy, the most recent data indicates that tumors that do not harbor a sensitizing EGFR mutation should not be treated with EGFR TKI in any line of therapy. So it's not enough to see the EGFR mutation only. We have to look what kind of EGFR mutation it is, whether it is exon 18, 19, 20, 21, or any other EGFR mutation, whether it is an exon insert, whether it is an insertion, translocation, or deletion mutation. Next slide, please. So osimertinib is a third generation irreversible CNS active EGFR TKI selective for both EGFR mutated and EGFR T790M resistance mutations, which is the secondary mutation. Osimertinib is selective for L858R and exon 19 deletion and T790 resistance. So inhibition of T790 is there, lower activity against wild type EGFR. It crosses the intact blood-brain barrier. Next slide. So FLORA data that led to the approval of the osimertinib in the metastatic setting. It was a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI as first-line treatment in patients with advanced or metastatic EGFR mutated non-small cell lung cancer. Next slide. So eligibility criteria, more than 18 years of age, performance status of 0 or 1, exon 19 deletion, L858R, no prior systemic anti-cancer therapy, or EGFR TKI therapy. Stable CNS mets patients were allowed. Stratification was done based on exon 19 versus 21 L858R, and by race, Asian versus non-Asian. So osimertinib in the standard dose of 80 mg per day only was randomized 1:1 to standard of care EGFR TKI at that time, that was geftinib 250 mg OD or erlotinib 150 mg OD. So RECIST 1.1 criteria was used for the response assessment. Crossover was allowed. Patients with confirmed progression by BICR on standard of care and T790M positive may begin post-progression open label osimertinib also. So that led to we will discuss it later, that what effect the crossover had in this study. So primary endpoint was PFS based on investigator assessment according to CIST 1.1. Secondary endpoints were objective response rate, duration of response, disease control rate, overall survival, patient-related outcomes, and safety. Next slide. So in the FLORA trial, baseline characteristics were well balanced across the treatment arms. Around two-thirds or 62% of the patients were females. Around 60, the median age was 64. Majority of the patients were Asian in both the arms, 62%. Around two-thirds of the patients were never smokers. CNS mets at study entry were 19 versus 23%. Performance status 0 and 1 in 40:60 ratio. 95% of the patients were stage 4. 99% of the patients were adenocarcinoma. And around 63% of the patients in both arms were exon 19 deletion compared to 37% L858R. Next slide, please. So coming to the primary endpoint, median progression-free survival is 18.9 months in the osimertinib arm compared to 10.2 months in the standard of care arm, giving an advantage of around 8 to 9 months with a hazard ratio of 0.46. As we can see, the curve started separating initially in the first few months only, before 3 months, and the separation continued till the study period. So osimertinib reduces the risk of progression or death by 54% compared to standard EGFR TKIs. Next slide. So PFS across the subgroups, overall we have seen the benefit was there in both males and females, but the benefit was greater in females. Benefit was there in both younger and older population, more than 65 years of age group. Benefit was there in both Asians and non-Asian subgroup, but the benefit was greater in non-Asians. So it benefited both smokers and non-smokers, both patients with CNS mets and without CNS mets, both performance status 0 and 1. The benefit was greater in exon 19 deletion mutation patients as compared to L858R. Centrally, a consistent benefit of osimertinib over standard TKI with respect to PFS was shown across all predefined subgroups. Next slide, please. So coming to the objective response rate, 80% versus 76%. Only 1% of the patients progressed in osimertinib compared to 5% in standard of care arm. Duration of response, again, the median duration of response was 17.2 months, which was almost double compared to the standard of care. Next slide. So FLORA, overall survival, the final analysis. Osimertinib, overall survival 38.6 months compared to 31.8 months in first line EGFR TKIs, first and second line. So giving an advantage of around 7 months. So which was clinically meaningful and statistically significant improvement in overall survival. Next slide. So coming to side effects were mostly grade 1, grade 2, and they were manageable, like diarrhea, rashes and acne, dry skin, stomatitis, anorexia, nausea, OTPT elevation in few patients. Next slide. So to summarize, osimertinib resulted in highly statistically significant and clinically meaningful improvement in PFS over standard of care, hazard ratio 0.46, 54% reduction in risk of progression of death, consistent benefit in all predefined subgroups, including patients with and without CNS mets, doubling of the duration of response with osimertinib, a significant and clinically meaningful improvement in CNS PFS over standard of care with a hazard ratio of 0.48. Final analysis, overall survival showed promising survival trend favoring osimertinib. Safety profile is comparable. Osimertinib is a new standard of care for first-line therapy in patients with EGFR mutation, advanced non-small cell lung cancer. Next slide. So coming to the CNS efficacy for osimertinib, which is very important in lung cancer, as we know, majority or around 50% of the lung cancer patients develop CNS mets at some point in their disease course. Next slide. So PFS in patients with and without CNS mets, 15.2 months versus 9.6 months with CNS mets, and 19.1 versus 10.9 months without CNS mets. So osimertinib benefit is consistent whether the patient has CNS mets or not the CNS mets. The hazard ratio is significant, 0.47 and 0.46. Next slide. So coming to the intracranial activity or CNS activity. So median CNS PFS is not yet reached in osimertinib compared to 13.9 months in standard of care. Hazard ratio again 0.48. So if we see the graph, the curve again started separating in the first 3 months only, like the full PFS. So we can say that osimertinib has a very good intracranial or CNS activity. Next slide. So comparing to the other TKIs, osimertinib versus dacometinib. Next slide. Next slide, please. So comparing across the trials, the Archer trial, Archer 1050, if we see the dacometinib versus ceftinib, for the first 6 months, the curves were almost nearby. They were not separating. The separation only happened after first 6 months. So whatever the benefit the patients had, it was after the first 6 months. In the first 6 months, the progression, the responses, the mortality was almost the same. While in flora with osimertinib, the curve started separating immediately. Next slide, please. So if you see the OS data of dacometinib ceftinib, it was 41 versus 33.6 months. But the point to note is that OS not statistically significant because the formal comparison of ORR was not statistically significant based on the study's hierarchical testing rules. So according to the predefined rules, the data it looks like it was better than the ceftinib, but according to the rules, it was not statistically significant. Next slide. While in the flora, the 38.6 versus 13.1.2, it was statistically significant according to the predefined rules. Next slide. So 54% of patients were alive in the osimertinib arm at the end of 3 years. Next slide. So overall survival with osimertinib in EGFR mutated non-small cell lung cancer. So it benefited like in PFS, in OS data also, it benefited both males and females, both younger and older population. It benefited non-Asians. It crosses the midline in case of Asian population. Benefited both smokers and non-smokers with and without CNS mets, PS 0 and 1. Exon 19, there was clear benefit in this OS data also, but L858R again it is crossing the midline. But here we have to see that crossover was allowed in this study. So many patients after progression received osimertinib as an open drug after progression. So that has an impact, had an impact on the overall survival. So it may be that is the reason why in Asian population and L858R we are not seeing that statistically that significant benefit which we observed in the PFS. Next slide, please. So, the dacometinib, gefitinib, again, it benefited both males, females, mainly the younger patients, so less than 65 years, Asian, non-Asian, smokers and never smokers. It benefited exon 21 L858R more than the exon 19, that is reverse as compared to osimertinib. Next slide. So osimertinib versus afatinib. Next, Lux Lung trial, Lux Lung 7, PFS 11 versus 10.9, afatinib versus ceftinib. Osimertinib has a median PFS of 18.9 months. There were insufficient events to determine OS of afatinib at the time of analysis. Next. So afatinib compared with gefitinib phase 2B open label, Lux Lung 7, 27.9 versus 24.5 months. Again, a non-significant significant survival advantage was not seen. Next. So safety profile, the safety profile was comparable. Diarrhea, stomatitis, and dose reduction only in 5.4% of the patients. While in afatinib and dacometinib, the dose reduction was there in more number of patients. Next slide. So FLORA was also a sequencing study. As we have discussed, the crossover was allowed. So first generation TKI to third generation TKI in around 47% of the patients. So first line osimertinib had better results compared to sequencing strategy. So hence the dilemma of sequencing is also resolved by FLORA, that osimertinib is a drug which is benefiting the EGFR mutated patients, but whether we should be giving it in the first line or second line, that dilemma is also resolved by this study by including the crossover. Next slide. Second line treatment, as we know, 30% of the patients don't have opportunity to receive any second line therapy. Also, it is not possible to predict who will develop T790M resistance, which is a secondary mutation. Next slide. So hence important to start with drug with greater benefit compared to other TKIs. Next. The use of osimertinib as second line therapy in FLORA was consistent with the expected rate in clinical practice. Around 30% of the patients could not receive a second line therapy. 47% of patients in comparator arm who did receive second line therapy received osimertinib only, consistent with expected rate of T790 mutation, which is around in half of the patients. Next. So coming to FLORA 2, which is a very recent data, it is phase 3 trial of first line osimertinib plus platinum based chemotherapy in EGFR mutated advanced non-small cell lung cancer. Next. So treatment naive patients with advanced non-squamous non-small cell lung cancer with exon 19 or L858R, TS0 and 1, stable CNS mets were allowed. Osimertinib in the standard dose of 80 mg OD, but this time combined with platinum-based chemotherapy, 279 patients, compared to osimertinib alone, 80 mg OD. So until progression or other withdrawal criteria met. Next slide, please. So baseline characteristics were balanced. Around median age is 61, 62. Majority, around 62% of the patients were female. Asian patients were well represented. Around 2/3 of the patients, PS0, 1, and few patients were 2 also. 99% of the patients were adenocarcinoma. Exon 19, 61%. L858R, 38%. Metastatic majority patients, CNS mets in around 42% of the patients. Extrathoracic mets were there in around half of the patients. 15 versus 24% patients had liver mets, and bone mets were there in around half of the patients. Next slide. So PFS according to investigator assessment, 25.5 versus 16.7 months. PFS according to blinded independent central review, 29.4 versus 19.9 months, which is significant. Hazard ratio 0.62 in both the cases. PFS among patients with CNS mets at baseline, 24.9 versus 13.8 months. Again, hazard ratio 0.47. PFS among patients without CNS mets, 27.6 versus 21 months, hazard ratio of 0.75. So benefit was there across all the subgroups. Next slide. To conclude, primary results of phase 3 FLORA-2 trial showed that combined treatment with osimertinib plus platinum-based chemotherapy significantly improved PFS versus osimertinib alone in treatment-naive patients with EGFR mutated advanced non-small cell lung cancer. 25.5 versus 16.7 months, around 8.8 months of benefit. PFS benefit was observed across all predefined subgroups. Mature PFS2 and OS data are awaited. Safety profile of is assumed well as expected and manageable. Investigators conclude that osimertinib plus platinum pemetrexed is a new treatment option for patients with newly diagnosed EGFR mutated advanced non-small cell lung cancer. Next. So NCCN guidelines for therapy as of 2024 first version, they recommend osimertinib as a preferred category in the first line EGFR mutated patients as compared to the other options. Osimertinib plus platinum-based chemotherapy is also now included in the category 1 other recommended treatment options. Next. So conclusion, for the first time in the evolution of EGFR TKs, osimertinib translated PFS to a significant OS benefit. Osimertinib with a median PFS of 18.9 and OS of 38.6 months is significantly higher than the first and second generation TKs. It has shown efficacy in patients with CNS mets. Fewer and less severe adverse events were there. Osimertinib is the new standard of care for first-line therapy in patients with EGFR mutated advanced non-small cell lung cancer. Thank you.
Thank you, Dr. Mukesh, for such an excellent talk. Now, I basically, in my talk, I will combine Dr. Sinha Bothra's Jain talk plus Dr. Mukesh Bansal talk, but I would like to discuss more from bench to bedside, the three cases, but I would like to discuss in the beginning the basic concept of brain mets. And everybody knows about that third generation TKI is basically crossing the blood-brain barrier. Dr. Ashish, could you share my slide?
Sir, I will share.
Okay. So my presentation is basically a combined presentation of Dr. Sanay Bothra Jain and Dr. Mukesh Bansal, but I will show you the three important cases which is reported in the journal regarding the response of the third generation TKI osimertinib in clinical practice for your consideration from bench to bedside. Sir Wangli, please share my slides. Yes. So my talk is basically focused on re-imaging CNS mutation in EGFR mutation advanced lung cancer, how treatments compare, and I would like to discuss three cases which is reported in the journals. Next slide, please. So just see the incidence of non-small cell lung cancer. 85% patients are non-small cell lung cancer and 15% patients are, you can say, small cell lung cancer. Next slide, please. So you can next slide, please. So just see, once we are talking about the non-small cell lung cancer adenocarcinoma, we have discussed number of times that EGFR mutations are seen in the tune of 17%, and from 1 to 5% you can see the BRAF, MAT, ALK, RAT, ROSI or NTRK in clinical practice, and RAS gene in the tune of 12% to 17%. Next slide, please. So you can say EGFR mutation is a driver mutation in adenocarcinoma, specifically in Southeast Asia or Asian company, those who are female, adenocarcinoma, bronchoalveolar carcinoma, non-smoker, the percentage of EGFR mutations are more. Next slide, please. So just see the global picture, which is very, very important for all of us. I'm highlighting few things which is very important. If you see the Western world, specifically the Europe, the EGFR mutation in the tune of 15% as compared to Southeast Asia, where you can see up to 62%. But I'm highlighting the global picture of EGFR mutation. Just see North America, this is in the tune of 22 to 27%. Latin America, almost same. Europe, 12 to 15 or 16%. Africa, 20 to 22%. South Africa, again, similar picture. Middle East is alarming us. Middle East shows a EGFR mutation in the tune of 8 to 12% maximum. This means the Middle East patients, those who are having adenocarcinoma, the mutations are much less as compared to the global picture. If you see the Australia, they are almost having a African site or a South African site picture in the tune of 23.8%. Why I'm discussing this? Because the response of third generation TKI with EGFR mutation is different globally. And once we are talking about the Asia, this is seen in the tune of 36 to 41% and maximum 62% in Southeast Asia, in specifically the women, non-smoker, bronchoalveolar carcinoma, adenocarcinoma, histopathology. Next slide, please. So, patient with lung cancer has the high rate of brain mets, and such incidents are more pronounced in EGFR mutation. I'm highlighting few things. Just see a final follow-up. 44% of the patient with EGFR mutation tumor had brain mets as compared to 22% with EGFR wild type of EGFR mutation. And leptomeningitis has a poor prognosis when not treated, and survival is almost, you can say, 4 to 6 weeks. Leptomeningeal metastasis may be more frequent in patients those who are having EGFR mutation in non-small cell lung cancer, and this is in the tune of 9.4. If you compare with the wild type, this is almost 1 to 2%. Next slide, please. So the quality of life is totally hampered once there is a brain mets. If you compare with the adrenal mets, liver mets, contralateral lung mets, and even the bone mets, you can say the 50% quality of life is impaired by the brain mets if patient is having single or multiple brain mets in non-small cell lung cancer, histopathology, adenocarcinoma. Next slide, please. So brain mets in EGFR TKI advance, what is the role? And everybody knows about that third generation TKI crosses the blood-brain barrier, and Dr. Sneh both are clearly mentioned about that. This drug is crossing, and even Dr. Bansal mentioned about that, the response rate of third generation TKI in brain mets in adenocarcinoma patient. Next slide, please. So what we already know, the brain is a sensory site. Everybody knows about that. For all the cancer, brain is the sensory site, even for leukemia, invading metastatic tumor cells, and it is protected by the blood-brain barrier. The blood-brain barrier is basically a barrier, but third generation TKI crosses that. Up to 40% of the patient of adenocarcinoma, EGFR mutation will develop the brain mets in due course of a time. As compared to wild variety, this is only 22%. So TKI are also substrate of blood-brain barrier and crosses that and showing the response rate. Hence, it is imperative that third generation TKI must be a good brain exposure if they are not to achieve intracranial efficacy. And my two previous speakers already conveyed that there is a response rate even in brain mets. Next slide, please. So this is the basically a penetration of this drug in blood-brain barrier in basically monkey, and picture is clearly showing a diffuse brain as compared to the first generation, second generation TKI like gefitinib and erlotinib. Comparing with the ositinib, the diffusion is seen in monkey brain. Next slide, please, in preclinical setting. So this slide is already shown by one of my speakers. So I'm not going in detail of this because blood-brain barriers 3.4, 0.1% as a plasma ratio, which is already discussed by my previous speaker. Next slide, please. Next slide, please. Next slide. So, ositinib caused tumor regression in EGFR mutation brain mets in a mouse xenograft model, and we have already discussed this. Next slide, please. So, ositinib was homogeneously distributed in all regions of brain in healthy volunteers, and you can easily see by these pictures that there is a distribution of ositinib seen in brain. Next slide, please. Ositinib achieved brain exposure in patient with EGFR mutation, advanced lung cancer patient, basically the adenocarcinoma. And there is a regional distribution and binding of ositinib on the PET parametric image, showing total volume of distribution in these pics. Next slide, please. Now, this is very, very important. The ositinib mechanism of action is basically irreversible to clinical relevant. I'm not going in detail of this, but I tell you, ositinib is effective in T790 mutation as well as in exon deletion, 19 deletions and L858R mutations seen in clinical practice. And everybody knows about that. The FLORA trial clearly mentioned about the prolongation of progression-free survival and overall survival as compared to first generation TKI. And third generation TKI crosses the blood-brain barrier, even effective in brain mets and leptomeningitis. Next slide, please. So, how does the efficacy of ositinib compare to first generation TKI in the treatment of adenocarcinoma advanced with EGFR mutation? Next slide, please. So, this is the FLORA study, which is already discussed by my friend. Metastatic disease 95% with 35% having visceral mets and 21% has CNS mets. Next slide, please. So this is the FLORA study results. Ositinib has significant longer overall survival as compared to the standard care of TKI. 24 months means versus 74% with ositinib versus 59% as a standard care of TKI, and 36 months means 54% versus 44% were alive, means 10% more in third generation TKI. Next slide, please. So, CNS progression event occur in roughly 6% versus 15% patient receiving ositinib versus standard of care, and the graph clearly separated with known or treated CNS mets versus without known or treated CNS mets. Both the graphs are separated, but if you see the without known treated CNS met, the response rate is 19.1 versus 10.9 and hazard ratio is 0.46. While if there is a CNS mets, the response rate is little bit less, 15.2 versus 9.6, and hazard ratio is almost same, 0.47. Next slide, please. So the results clearly shows that 74 versus 59 and 54 versus 44, which I've already discussed with you. Next slide, please. So intracranial CNS progression-free survival versus CNS full analysis set, you can see very clearly the graph is separated since beginning, and ositinib not reachable versus 13.9 with the standard care of TKI, hazard ratio 0.8, median follow-up months were 12.4 months versus 7 months, and CNS progression-free survival was statistically significant with the third generation TKI as compared to first generation TKI. Next slide, please. So the FLORA results are very clear. CNS progression by independent blind review committee occurred in 20%, ositinib versus 39% with the first generation or a competitor TKI. Next slide. So in the FAST, which include patient with and without CNS mets are trial entry, investigator assist CNS progression event were observed in 6% of ositinib versus 16% in competitor standard of care TKI. Next slide, please. So the trials clearly show 12 months, 24 months, and 36 months. At 36 months, the ositinib arm is showing 28% versus 9% with the standard of care of TKI. So first line osimertinib may delay the need for subsequent therapies, which is clear now. And 28% versus 9% continue to receive the first line trial drug at 36 months. So this means the third generation TKI is a better drug as compared to first line or second line TKI. Next slide, please. So some real world evidence of osimertinib with CNS mets. I am presenting 3 cases. Next. So rapid intracranial response to osimertinib without radiotherapy in non-small cell lung cancer patient harboring the EGFR T790 mutation, as Dr. Sneha Bothra mentioned about in her presentation and during the discussion. Next slide, please. So first case is, next slide. Next slide. So 67-year-old male basically underwent right middle lobe resection of lung because of an early stage of lung cancer 9 years ago. Multiple nodules emerged in both the lungs on CT 7 years ago, which was recognized as a recurrence and identified as a EGFR L858R mutation in exon 21. Patient was on gefitinib first line chemotherapy for 2 years and 11 months. After 3 lines of cytotoxic drug regime like carboplatin plus pemetrexed, Tagafar, Gemcitabine, and oroflexacin plus bevacizumab and docetaxel, erlotinib was administered as a 5th line treatment, which failed in 3 months, 3.5 months only. After 2 courses of vinorelbine administration as 6th line chemotherapy, patient complained of unbearable back pain and spinal MRI examination, deducted multiple thoracolumbar bone mets. Radiotherapy was conducted to control pain and prevent fracture. Bronchoscopy has been conducted as a rebiopsy, as Dr. Sneha Bothra mentioned, even in a brain mets case, and even the recurrence at the primary site, detected as an additional mutation, T790 mutation in exon 20. A 7th line chemotherapy means osimertinib 80 mg was administered from the next day, and PS that time was 3. Next slide, please. So this is the pic of the MRI of patient. The pre-treatment shows there is a brain mets, but day 13 the brain met disappear with the osimertinib third generation TKI. This is a real world picture. I am showing you the case which is presented in the journal, and the patient has an excellent response on day 13. Multiple mets at baseline, completely remission of brain mets, except for one in the left frontal lobe after day 13 of osimertinib treatment. And even at the primary site, there was a shrinkage of right pulmonary nodules after day 5 once we administered third generation TKI osimertinib in this case. Next slide, please. Now I'm discussing the second case. Next slide, please. So 76-year-old male with 22.5 pack year smoking history, means just see 76 with roughly 22 or 23 packs cigarettes, underwent right upper lobe resection of the lung because of the early stage 10 years ago. EGFR exon 19 deletion, multiple bone mets as a recurrence emerged 6.5 years ago. Patient was on a first generation TKI, first line chemotherapy for 4.5 years. Second generation afitinib was administered for 10 months and sandwiched 4 courses of pemetrexed and carboplatin given with bevacizumab. While 4th line chemotherapy, Tagafar, Gemcitabine, and Otricil was given, pleural effusion with right-sided dominance was seen. A thoracocentesis was conducted and detected the additional mutation, as Dr. Sane and Dr. Bansal mentioned about that. T790 mutation seen in number of patients in exon 20, and third generation TKI is effective in such cases. Osimertinib was administered as a 5th line chemo. Next slide, please. So just see on the day 10 of administration of osimertinib, brain CT revealed the remission of a single brain mets in the right parietal lobe, which was asymptomatic. Number 1. Second thing, on day 14, decrease of pleural effusion and shrinkage of pulmonary nodules were recognized apparently on chest X-ray. Third thing, after a month, CT chest image revealed shrinkage of multiple lung mets and decrease of left-sided pleural effusion. Performance status improved to 1 and decrease of pleural effusion. Next slide, please. So this is the picture. The pre-treatment and day 10, you can easily see there was a complete remission of single brain mets after day 10 of osimertinib treatment. Next slide, please. And this is the primary site pre-treatment, the X-ray as well as CT, day 31 and day 14. You can see on day 14, decrease of pleural effusion, shrinkage of pulmonary nodules, and after a month gap, shrinkage of multiple lung mets, decrease in left-sided pleural effusion. Next slide, please. Now I'm discussing the third case, which is again reported in the journal, complete remission of multiple brain mets in a patient with EGFR mutated adenocarcinoma patient with first-line osimertinib without radiotherapy. My word is without radiotherapy. Next slide, please. So again, a 74-year-old woman with no history of smoking. She is non-smoker. We discussed two cases. Those were chronic smoker and massive smoking by the history, elevated blood CA antigen levels, and CT scan revealed a 40 shadows in the upper lobe of left lung and multiple bilateral small nodule in the entire lung field. And clinically diagnosed T4N1MC1 stage 4B lung cancer, adenocarcinoma, EGFR mutation, exon 19 deletion mutation positive. More than 20 multiple asymptomatic brain mets with a maximum diameter of 12 millimeter were detected via MRI. And for any brain mets, we prefer to go for a MRI and see the brain mets and number, size, and location. Osimertinib 80 mg once daily was administered as a first-line treatment, and whole brain RT was deferred. Next slide, please. So this is the CT scan of this patient, and the picture suggestive of T4N1MC1 stage 4 lung cancer adenocarcinoma, 40 millimeter white shadows in the upper lobe of the left lung, multiple bilateral small nodule in the entire lung field. Next slide, please. And this is the brain picture. Multiple asymptomatic brain mets lesion, more than 20 with a maximum diameter of 12 millimeters were detected at the first diagnosis. You can easily see in this picture. After 5 weeks, the multiple brain mets had disappeared completely, and you can see and you can compare the above and below pictures of MRI, and there is a complete CNS response was confirmed by osimertinib in this case. Next slide, please. So intracranial outcome of de novo brain mets treated with osimertinib alone in patient with newly diagnosed EGFR mutations, exon 19 deletion seen. Next slide. So in this observation, retrospective coherent study, patient was selected for an institutional database, and just see that patient is having a mutations, basically mutation detected in adenocarcinoma. Osimertinib was given initially alone. After first brain mets diagnosis, had at least one intact brain mets not previously treated with systemic or local therapy, stereotactic radiosurgery, while brain radiotherapy or surgery, and at osimertinib initiation end. Third thing is, had a baseline brain magnetic MRI, means MRI, and at least one scan after osimertinib initiation. Next slide, please. And this is the baseline picture, which clearly shows there is a disease. And 2 months post osimertinib, you can easily compare that the brain was shown excellent response. And 34 months post osimertinib, there was an excellent response. You can say disease control was seen until 34 months post osimertinib in this MRI from baseline to response. 2 months and 34 months. Next slide, please. So observation was that in 36 patients who had a median interval from brain mets diagnosed to first-line osimertinib, initiation of 25 days, and total 136 patients seen, and objective response rate was 100%. 2-year overall survival was 80%. CNS progression rate 1 to 3 years means first year, second year, third year post ositinib 21%, 32%, and 41% respectively. Lesion level local failure was estimated to be 0.7% and 4.7% at first year and second year post ositinib respectively. Next slide, please. So, what are the recent guideline updates suggest? And Dr. Bansal has shown the NCCN guideline, and even Dr. Sanev, both Raj and clearly mentioned about that these are the recent guidelines. I'm just refreshing these guidelines again to update ourselves. Next slide, please. So this is the NCCN guideline, and India we are following, and this is 2024 guidelines. Next slide, please. Basically, this is Dr. Bansal's slide, which is already seen by you. I'm again highlighting that the first line therapy preferred osimertinib category 1. The other recommendation, which Dr. Bansal clearly mentioned about that, you can combine with the pemetrexed cisplatin oblique carboplatin if patient is fit or you feel that there is a need. Otherwise, you can go for a single agent osimertinib as a category 1 recommendation. My word is preferred one as by the NCCN guidelines. Next slide, please. So I can say that today we learned so many things regarding the lung cancer, specifically with third generation TKI, osimertinib, and I personally feel that every expert share their experience and shown the guidelines. I really thanks all the speakers and the AstraZeneca who has given me this opportunity to discuss all the issues regarding the lung cancer in this oncology cancer treatment update. Thank you very much listening me patiently. The mic is hand over to Ashish Gupta or Miss Patil for vote of thanks.
Thank you, sir.
Thank you so much, sir. Thank you everyone for joining today's webinar. We'll meet again. Good night, everyone.
Good night to all of you.
Support team, close the meeting. Hello.
Support team, please close the meeting.